Good afternoon. Welcome to the session, If Seizures Return After Surgery, Promising Genetic Precision Treatments for Epilepsy. I have the pleasure of introducing Dr. Achkar. She is an attending physician in the Epilepsy Genetics Program in the Division of Epilepsy and Neurophysiology at Boston Children's Hospital. Dr. Achkar's main research and clinical interest is precision medicine and the application of novel therapies in rare genetic epilepsies, including ASOs. I'd like to welcome Dr. Achkar. Thank you for being here.
Thank you very much. It's really a huge pleasure for me to be here. I will be talking today about the impact of genetics and precision medicine on several areas of epilepsy surgery. If you see the title that's on the program, Monica pretty much tasked me to fix epilepsy even when surgery cannot take care of the seizures. But while we are not there yet, I think there have been a lot of changes and a lot of improvements over time, and I think we are really on the right path to continue to get better outcomes for our patients. I'm just going to start quickly with the disclosures. There's really nothing that's in conflict with today's lecture, but because I work a lot in clinical trials and precision medicine, I have been a PI with several pharmaceutical companies. Very importantly, too, is even though I'm talking about what to do with genetics, I'm by no means against surgical management. I do think that there are definitely cases and places where surgery, for the time being, is the only way to go. I'm going to divide today's discussion into 4 aspects when it comes to how genetics impact epilepsy surgery. The first one is the diagnosis. Second one is prognosis. Third is how does it impact decision making and how can it help? And finally, how does it affect the treatment and how we view the future of therapies in epilepsy, in surgical epilepsy. Basically, we're going to try to answer a couple of questions here. How do genetic changes lead to focal epilepsy? And by focal epilepsy, I mean it's the seizures that tend to come from just one area of the brain. Are there genetic syndromes where there is actually a generalized epilepsy or epilepsy coming from different areas or the whole brain at once, but that are still amenable to surgical management? And should genetic testing become part of the workup of anybody who's presenting for epilepsy surgery? First, I would like to talk a little bit about the concepts of the timing of when the genetic change happens. And this will include the 2 words. One is germline and one mosaicism. So when a germline change happens, that means that the mutation or the pathogenic variant has happened before the first cell of the baby has actually been formed, which means that that change will affect the entire body of the child, meaning that every cell of the body is going to have that particular change. In contrast, germline changes are changes that happen a little bit later they're still very early in the development, but they do happen a little bit later, and they happen in just a subset of the cells, so that the change is not really found in the entire body, but sometimes it can happen in specific areas of the brain, for example, where you would see a change in only one area of the brain. So if you can see here, the images A and B next to each other. This is an image of a normal brain MRI. There are really no changes that are seen here. Moving to C and D, there is a change that actually happened in the germline and that affected the entire body, all the cells of the body. And an example of that in when it comes to brain malformations is lissencephaly, where the entire cortex of the brain tends to be malformed. And moving on to yet another example, which is a change that happens early but later than the formation of the first cell of the baby. And an example of that is, for example, what we call double cortex syndrome, which is that some cells have gotten the proper gene and they know where to go and they've gone all the way out to the cortex, while some of the cells had the mutated gene and did not really have the cues or the path to travel all the way out to the brain, and they got stuck inside the brain, forming yet another layer, which in itself is conducive of seizures. And then the fourth and final example I will be giving here is when a change happens down the line and affects parts of the body or a subset of the cells. And one example here is when you have unilateral or hemimegalencephaly, which means one hemisphere of the brain is enlarged. It grows in this particular way because the genetic information that's in those cells does not follow the normal trajectory of cellular growth and cellular migration. So I just wanted to draw these differences because they will come important when we start to think about the genetic causes of epilepsies when we think about surgery, and that also has an impact on the prognosis and what we think could happen. I will by talking about the genetic epilepsies where we tend to see focal seizures. In the majority of these examples that are on this particular slide, the seizures can occur from one area or they can occur from the whole brain. But for the vast majority, we don't really see any abnormalities on the brain MRI. There are subsets of some genes where actually they are associated with a very focal brain abnormality that we can go after, but many of them are not. And so these are important to try and diagnose in order to think about what the process of treatment and what could the surgical plan look like. The way that some genes will cause the brain to become what we call epileptogenicity, or to become prone to having those seizures, there can be abnormalities in the channels, and specific examples include SCN1A, which causes the more commonly known syndrome in genetic epilepsies, which is Dravet syndrome. Other channels include SCN2A, SCN8A, KCNQ2, which are potassium channels. With all of these, you can see focal seizures, and they might always look like they're coming from one area of the brain. And yet, we know that the variant or the change is affecting the whole brain and the whole body. Another way those genetic changes can affect the brain is they can affect the way the cells communicate with each other. That's at the level of the synapse, what you call as synaptopathies or synaptic protein abnormalities. And again, I'm just sharing some genes for reference. There is really the goal is really not to learn or put all of the genes that we know about, but just to share a few examples of where out of a genetic abnormality involving the whole body, we end up seeing seizures that are focal. There are metabolic disorders as well. One of them is commonly known as glucose transporter 1 deficiency, and that can present, while it can present with full generalized seizures, full brain seizures, it can present with pretty focal seizures. Regarding the signaling pathways, I'm going to jump in and give them their full slide because they are very important pathways in the development of focal epilepsies. And some of them actually do involve the entire body and you can find the change in every single cell of the body, some of them you might only find the change in the tissue that is affected. Specific examples of this, I think probably the more commonly known and the oldest that has been discovered is the tuberous sclerosis complex. The more recently discovered complex is called the Gator-1 complex. And basically, these are all what they have in common here is this mTOR molecule. When the mTOR molecule is not doing the job the way it's supposed to be, it typically is overacting or over performing. We end up having abnormal signaling in the cells, and the cells either grow more than they're supposed to or form connections that can lead to potential seizures. And in tuberous sclerosis, for example, we will almost always see a brain malformation or several brain malformations. With the Gator pathways, and I'm going to list those genes just because they are important. I think it's important to look for them in general. The oldest one that was discovered was DEPDC5 or DEPTIC5, and then the other two are NPRL3 and NPRL2. In those situations, the MRI of the brain might be completely normal, but at times you can also see some malformations. We talked also about what do we do in those genetic epilepsies where there is a generalized or multifocal seizure onset, and these are the types of genetic epilepsies where we would consider a corpus callosotomy. Tends to be any genetic syndrome associated with drop seizures, which are just sudden falls, or tonic seizures, which are stiffening seizures. And these include Dravet syndrome, other causes of the Lennox-Gastaut syndrome, which is characterized by frequent falls and tonic seizures, as well as other chromosomal abnormalities. And then in terms of thinking about, do we really need to do genetic testing as part of the surgical workup? You can see that these are really the main papers on the topic. They all date from the last couple of years. And I'm glad to see that this is starting to become more of a question, and people are thinking more about it, because sometimes we tend to think that if I'm going for surgery and I want to resect some tissue, why does it matter what the genetic cause is? And it's probably not going to be genetic because I'm dealing with a focal epilepsy. So I'm going to review a couple of these studies and what they found. In one of the studies from 2023, they looked into a total of 74 patients who underwent surgery, and 13 of them actually were found to have a diagnosis, and that was germline, meaning they found it in the blood, which is not the majority, but that is a rather significant number. When then they went and looked at the tissue from the brain, they did find that 10 out of the 35 patients that they looked at actually had a specific genetic cause for that malformation or that area in their brain. Their conclusion when they looked at the outcomes was that there was really no difference in seizure outcomes when they compared the children and the patients with positive genetic findings to those without genetic findings. Now here they just compared both groups to each other without necessarily going into the cause of each of the abnormalities. However, I think the message from that paper really was that just because you have a genetic abnormality, this does not automatically mean that you're not a surgical candidate or that your outcome is not going to be as good as if you did not have a genetic abnormality. Another larger paper there where they looked at 125 patients that were referred for surgery. 69, almost 70% of them had genetic testing, which is really a decent number in that particular study. And out of those 86, 21% were actually diagnosed with a genetic condition, and they could confirm that 12 of those that the cause was the likely cause of epilepsy in at least 12 of those. The way it affected this cohort was, first of all, 3 patients who were diagnosed with a particular genetic condition opted out of surgery and were able to use or benefit from specific medical therapy that was targeted to their condition. They also mentioned how the impact on counseling regarding outcomes was changed because of the genetic genetic findings. They did not go well into the overall outcomes, but they did mention as well that the outcome is really case dependent and cause dependent. And then the third and final one that I will be reviewing today is where they saw not in a center, they followed 9 patients with focal epilepsy who did not have any MRI abnormalities. They found that 7 out of the 9 had a positive genetic finding, which is quite a large number. They did conclude, however, in that particular study, that having a genetic diagnosis gives you a less favorable outcome from epilepsy surgery. And they highly recommended genetic testing prior to surgery, especially if it's non-lesional. To conclude this part, I do believe that genetic testing should become a routine part of surgical evaluation, especially when there's no lesion on MRI. Genetic result can help understand the overall disease process and better understand how a surgery could help or change that disease process. And it also helps us better understand what the outcome can be. Next, I would like to move to the question of prognosis. And the main question here is, should genetic testing results truly affect surgical candidacy? And what are the available data on surgical outcomes in patients with genetic epilepsies? As I mentioned from the 3 studies on the previous slide, they didn't really go into dividing what the cause is and how that affects the outcome. But I'm going to go over this particular study here, where there was a decent follow-up, where they were able to see how many of these children actually became seizure-free after surgery. In this particular group, they had tested 49 children who underwent epilepsy surgery. 19 of them were found to have a genetic cause of their epilepsy. When they put all of the groups together, what they concluded was that children with positive genetic findings had a less favorable prognosis in general than those without a positive genetic finding. But if you look at it, when you look at the green part here, which is the Engel class 1, which is basically seizure freedom, that number, that percentage, it's still pretty decent. It's at least 15%. It is a little bit larger in the other group, but there is still a good amount of patients who do have favorable prognosis, even though they have a genetic diagnosis. In this next slide, we will look a bit into who are those patients who actually have a better prognosis and who are those patients who actually have a less favorable prognosis. And if you remember when we talked about what are the mechanisms that cause epilepsy in the brain, we talked about the channel abnormalities, the synapse abnormalities, and I think, as expected, given that these tend to affect pretty much all the cells of the brain or a large amount of the cells of the brain, even if the seizures are coming from one particular area, there is still a high chance that the seizures will happen around that area or from different parts of the brain, and surgery might not have the same impact on overall cognitive development. And so in this particular study, they found that the least favorable outcome was in those patients who had channel and synaptic abnormalities, while the better outcome was found in those who have, when you see, so this is the enteropathies, this is the image where I showed you the signaling between the different complexes, the tuberous sclerosis one and the Gator 1 complexes, and they found that those who tested positive for any of those genetic abnormalities had a much better outcome. And I think there are a couple of theories as to why that's the case. Number one, many of them actually had a very clear lesion, and they could go after it. They knew exactly where the seizures are coming from, and it was successfully resected. Another reason is that in some of them, the change might not have affected the entire brain the same way, and there was only this particular area that was affected and was successfully resected that was causing the seizure, even when there aren't clear malformations there. Again, when we talk about more favorable, less favorable, it still doesn't mean that we are saying it's contraindicated to do surgery, but at least it helps us better understand what the prognosis could look like. In terms of thinking about this decision, if you have a child or a patient with a genetic epilepsy and the seizures are really not remitting, not improving, and what can help us decide whether we should do surgery or not? First of all, it's really case-by-case basis, and it's really based on each child's genetic abnormality. And so knowing the surgical success rates in all of these different genetic conditions can actually help have an idea of what the outcomes could be. Of course, every child is different, and it's really difficult to generalize and say, you know, and give hard numbers, but at least you can have a sense of what it could look like. Having clear expectations when you discuss these expectations with your physician, with your family, and better understand what they mean, I think can definitely help clear the some of the questions. And I think the risk-benefit balance is important, and the risk-benefit is very, very different from one family to another, from one patient to another. It's really a personal decision to be made. Of course, you will do it with the help of a physician, with the help of a neurosurgeon. You're going to go over the data, the risks, the statistics. But at the same time, I think each family and each patient thinks about, what do I have to gain and what do I have to lose? And in general, it tends to be that sometimes the higher risk treatments are those that are most efficacious, but it does not have to be. It does not have to always be that. I think where you really, really want to be, and I don't know if you can see my cursor. No. Let me see. There's a light here. But you really want to be near the arrow, near the end of the green arrow, where you have the highest efficacy for the lowest risk treatment. And sometimes this is not possible, or even feasible. And I think that this is where you would start to think about, very specifically and in a lot of detail, what are the things that this surgery is going to help me with, and what are the things that I could potentially lose because of this surgery. Again, to sum up these two areas there, a genetic diagnosis should not be a contraindication for epilepsy surgery. The outcomes still depend on the cause and the mechanism, and therefore they are different between different conditions. The outcomes tend to be better in genetic disorders where you see a focal MRI change. Outcomes can still be favorable in other conditions if a clear seizure focus is found, or if the particular genetic syndrome is known to have MRI changes. Resective surgery might not be the best option in conditions where you have multifocal epilepsy or generalized epilepsy or diffuse abnormalities such as with the channel abnormalities and the synaptic abnormalities. However, there are other types of surgeries that could still be that could still be suitable, such as corpus callosotomy, where the right side of the brain is separated from the left side of the brain in order to prevent the rapid spread of seizures, especially drop seizures. Vagal nerve stimulator and deep brain stimulator, which both are supposed to try and calm down the overall and general activity of the brain. So these 3 procedures are not based on the location of the seizure. And then finally onto the treatment discussion. So what I would like to do first is to go a little bit into what precision medicine in epilepsy is in general, and think about how can we apply that. Can that be applied to all of the genetic epilepsies, even those that might require surgery for management? And then we'll talk about what are some of the gene-based therapies that we know of when surgery is not an option, or the surgery does not lead to the desired outcome, and what do we know about that, and what are the future directions? So our first level of attacking or addressing the seizures tends to be related to the seizure type. We have specific medications that we know help particular seizure types, regardless of the cause. Moving on from that, we also know that there are specific medications that help with the overall seizure syndrome. For example, again, regardless of the cause, but for example, to make it a little more specific, let's say we have Lennox-Gastaut, where there are different seizure types, and it is a particular syndrome, and it has several medications that are known to help in this particular syndrome. There are other reasons, again, where or other types of syndromes or causes where we have to address differently, such as with surgery or immunotherapy in immune epilepsies. But then moving on to the next level of precision, and I would like to start reading up the slide from bottom to top, because this is we are going into the more precise level of treatment. When you really look at the main outcome, the main problem when there's a genetic abnormality is that the protein that gene is supposed to code for is abnormal. And so there are several types of medications or treatments that can help either fix the function of that particular protein, or take over the function of that protein, or even minimize its function if it's one of those proteins that is overacting. And that, again, tends to be a lot of oral medications. Some can be the typical anti-seizure medications that we choose. Some might not be the usual anti-seizure medications, but can really help with the seizures. And then, so if we want to go backward and say, so where did this protein go wrong? What happened? And we can think about addressing the abnormality at the level of either the DNA or the RNA, which are really the building blocks of the genetic code. The DNA is really the main area where the changes are happening that are going to cause this trickle-down abnormality. And that, in general, needs to be targeted through proper gene therapy, meaning you are replacing an abnormal gene by a normal gene. And then there are the other technologies where you're actually not necessarily replacing the whole thing, but editing it through CRISPR-Cas9. We do not have a lot of data yet on that, on how to use it in surgical epilepsies. And then in between those two, when instead of trying to fix the gene itself or the protein itself, we can try to fix the messenger in between the two. And that has so far been done through something called antisense oligonucleotide therapies, where basically you get a small segment of of a copy that's actually going to go and get stuck on that messenger that is supposed to form the protein, and decides or helps that messenger decide how is it going to form the protein, or is it going to form it at all, because as I mentioned, there are some conditions where the gene is overworking actually, and you just want to decrease the amount. Now, those two top levels are actually very precise, and they are very disease specific, and that really requires knowing the absolute cause, the genetic cause, and targeting that very particular area. And with that, we have been using those more so in other types of epilepsy, not yet in the lesional epilepsies or the focal epilepsies per se, but we hope that more work will be done on that in the near future. Just to give an example of the levels of when we think about a condition and what are the levels of precision that we think about, I'm choosing SCN1A, which is associated with Dravet syndrome, just because it is a more common occurrence in children with epilepsy. It is also one of those genetic conditions that can be associated with focal seizures. And there are cases where we have seen children come in for surgical evaluation, and we needed to make sure that actually this is not the cause. So again, you can think about what seizure types are associated with this gene and use the seizure medications to target those. Or how does the protein malfunction in this gene, and choose the medications that either help the function of the protein or at least don't make it worse. And then third, and again we're getting even more precise, is we want to target what went wrong with the gene, the message that's coming from the gene, to make sure that we form better protein or a larger number of normal proteins. And that can be done through either gene editing, which it has not been done in a human yet, or those antisense oligonucleotides. And I'm going to share just this one example from the group at Ann Arbor that worked in tandem with Stoke, which is a pharmaceutical company, to devise this small molecule, which is an antisense oligonucleotide, that when you actually give it goes and it really affects the way the protein is going to be formed. And the way it works is that it enhances the formation of the normal protein, and it actually decreases the impact of the abnormal protein by basically getting rid of any of the unnecessary or non-essential fragments that might come out of there. And with that, you end up with a channel that is functioning better, and with a larger number of channels that are functioning better. So far, it has shown promising results with significant improvement in certain types of seizures and a positive impact on behavior and cognition. I think this is really the classic example of precision medicine right now that we have in epilepsy in general. That does not necessarily impact epilepsies with where there is a brain malformation. However, there have been several studies on surgical management in patients with Dravet syndrome, as some of them actually might end up having a small brain malformation, and the outlook or the outcome has not been very good. The seizures did not really improve after surgery. And I think this is one of those areas where a therapy such as this one, and this is just an example, could potentially be an option, either instead of surgery or if surgery does not help. Moving on to get closer to the focal epilepsies, and again going back to this pathway that tends to cause a lot of the focal epilepsies that we see, some with brain abnormalities on the MRI and some without. This has been thought of for several years now as one of the main targets to try and help with the seizures. There are a couple of thoughts on this particular process. One of them is, if that malformation is there and you're born with this malformation, how can a medication go and change? The malformation is already there and it's fixed, and the medication cannot change the malformation itself. However, there are data, and I'm going to show in the next slides, that have shown that there is actually a positive impact on seizures in these particular areas when you use a medication that blocks the effect of this particular molecule here, again, the mTOR, which causes a lot of troubles that lead to all of these abnormalities. And part of it could be that even though it's not affecting the malformation itself, it can affect the way the cells are signaling between each other and decreasing the risk of having seizures, or basically making the threshold higher so that the kids do not have as many seizures. To give an example to that, one of the trials here that was done in tuberous sclerosis. So this medication, everolimus, it's an oral medication, and it is a medication, again, that blocks that mTOR pathway so that the other proteins can work normally. And it has actually been shown to have a very positive effect on seizures when it was used in a phase 3, meaning they were actually able to compare affected individuals who were on placebo or non-drug to those who were on everolimus, and they really found a significant impact on seizures themselves, regardless of the fact that they had different abnormalities or different tubers in the brain. And so this is one area that we are all hopeful for, and it needs to be explored a little bit more. It needs to be explored in the sense of, does earlier treatment affect the overall outcome? Is there a different way to administer this treatment for it to become more effective? And are there any other areas of that pathway that should be targeted? But for the time being, these drugs have been the main ones that have been trialed or used in these particular causes of epilepsy. And these are the causes that end up leading to surgeries in most of the cases. I would like to give a case example right here. Again, this is a single case, which we do not really want to generalize based on it, but at least it gives us some insight that there is a possibility of certain medications helping even when there is a large malformation. This is a report from a patient who had hemimegalencephaly. And again, what you see here, I'm going to show you, if you look at where it says T2, that image that is right under T2, you can see how one half of the brain is larger and less well-formed than the other side of the brain. And that's not going to change. Medication is not going to change that configuration, that shape. But it was found to be caused by one of the genes that are affected by the mTOR pathway. It was actually the mTOR gene. And in this particular little patient, the plan was to go forward with surgery, but they wanted to wait until the patient was a little bit older. And in order to help with the seizures, they tried her on this mTOR, one of the mTOR blockers. In this particular situation, this was called rapamycin. And so what I want you to look at here is, if you see the blue lines there, those blue lines there represent the severity and the amount of seizures. And on top, you can see the seizure duration of how long those seizure clusters were taking place. Initially, they were up to 2 hours. Then they got a little bit shorter, but continued to be up to 1 to 2 hours. And then rapamycin here, and you see the green, this is where rapamycin was started. And there was a significant decrease in the overall number of seizures, as well as the overall duration. And there was an improvement on the EEG, and you don't see it right here, but there was also some improvement in cognition. Again, this is not the ultimate treatment, and we don't expect this to prevent. Even if it prevents a large number of the seizures, it's unlikely to render someone seizure free. It is also unlikely to prevent some of the neurodevelopmental impacts of this malformation. But at least it is an option that we can use while waiting for a surgery, or even if a surgery is done and for some reason it was not 100% successful, or another abnormality was found in a different area of the brain, this could be an addition to that might improve the outcome. And so, in conclusion, we talked about the brain malformations, and they're not really going to be reversible, but there are some agents that can still affect that propensity of the tissue to cause seizures and to be epileptogenic the whole time by really targeting the abnormal genetic problem. We really need larger studies specifically for the focal cortical dysplasias, which are the single lesions that are seen in the brain, and the hemimegalencephaly, like this last kid that I showed you, and other brain malformations. There are more studies in the tuberous sclerosis than with these, but of course we continue to need more. In children who have had epilepsy surgery and it was a non-lesional epilepsy and no clear cause was found, I would still highly consider getting genetic testing, even if it's been years, because we have a lot of new genes. There are new genes that get discovered every few days, and there is a lot more. There's a higher likelihood right now to actually find a positive answer. And with that, depending on the finding, that could lead to a potential for some gene-based therapies. And I will end with this, and I just want to say, it's really wonderful to be here because a lot of the work we do really is not meaningful unless we get the input and these questions, and you telling us exactly what we need to be looking for and what do we need to be researching, so that our kids have a better quality of life. And I'm happy to take any questions.
I have a question.
Yeah.
Okay, so my daughter had a left-temporal lobectomy at Olson Children's under Dr. Madsen. She's been seizure-free for 6 years. She had classic multiple sclerosis. Is there a reason why I should maybe ask Dr. Pearl, should we send her pathology off? I'm so curious. This is just so fascinating to me, because I think when we were going for surgical workup and everything, I don't know if genetic testing was so readily available. And I'm not sure because it's not fresh. I assume they keep her pathology inevitably or whatever, but so that's kind of my.
Yeah, I mean, this is a great example, especially that thankfully she's doing well. So no matter what result we get, it's not going to change what we do or what she's going to become. But I think at the time of surgery, if there is a thought that the abnormality or the malformation is of genetic origin, it can be useful to do it at that time. We are still limited by what we can do on the tissue itself. There are only a few labs in the country that will run those genes, but there are a lot of research where they have repositories where they keep analyzing those tissues, and so some of these genes have been trickling down throughout the years. But sometimes with mesial temporal sclerosis, it does not end up being a genetic cause. It ends up being more of either a recurrent injury, either from seizures, or sometimes we don't know why it happens.
We think that we're all seizures.
That's exactly, and while that remains debatable, it's the only explanation. The only explanation that we have. But if at any point she's curious, I think, with her own future, and if she wants to think about her own family, she can always think about doing her own genetic testing. More importantly, on the blood, because if it's something that's just in the brain, she's not going to transmit that to the children. But yeah, that's that. And again, I'm hoping in the near future there'll be easier tests to do to detect that. Yeah. Yeah.
So actually, my daughter had first surgery and also autism, and but she doesn't have any component of catamenial pregnancy. And I want to see if maybe you have any insight in terms of genetic causes of catamenia. I know that like some hormones like
Yeah.
progesterone versus
Yeah.
estrogen, they
Yeah.
change the level of activity, the immune system.
Of course.
That, I mean, not everybody is affected by
That's correct.
catamenia. Why is it that some are more prone to catamenial versus others? What is the genetics basis for that?
There are a lot of levels to this. I think when we think about what are the seizure types or the seizure syndromes that are more prone to have catamenial epilepsy or seizures really concentrated around not necessarily the period itself, but a specific time. It could be before, it could be after. We tend to notice that the generalized epilepsies, which we call now genetic generalized epilepsies, have a much higher chance to have a catamenial component. And those epilepsies, we don't know what the genetic cause of them is. We think they are multigenic, meaning there are a lot of different changes that have to happen together for them to actually lead to this particular epilepsy and to that risk. So maybe there is a risk along with that polygenic complex there that is also associated with catamenial epilepsy. But then the next level there is starting to think about not necessarily the genes associated with the epilepsy itself, but some other genes in the body which will impact how you respond to having seizures. And I think at the end of the day, a lot of the things that happen do have a genetic component. I mean, even brain trauma, why some people behave one way after a brain trauma and others don't, that has a lot to do with the genetics and what genes are being activated or deactivated at a particular time. I think that there will be more studies on this. There's a group at the Brigham actually who is really focused on epilepsy in women and on what medications to do and how to manage catamenial epilepsy. And I do think that part of that group is looking into the genetic substrates. I'm not aware of a name that I can give you. This is the gene that causes this. But I do think that there could be a genetic component just because we see it more in the genetic generalized epilepsies. We can still see it in the focal epilepsies too.
Do you think it's beneficial to that group, or is like if I can because my daughter has fluent like having
Yeah.
Dr. Herzog actually
Uh-huh.
with all of her data and
Yeah.
numerically
Yeah. Usually we go to Dr. Hertz. We send our patients to Dr. Hertz. Depends on how old she is.
and she's 21.
Oh yeah, she could certainly, you can certainly call and see what the program's like, and I think it would be good not just to figure out the cause, but also the management over time, especially at her age, and she's an adult now, so it can really be impactful to see them. Oh, you're gonna ask me a very hard question.
No, they'll be
Just it was really interesting to see the anthropology channel singing in market. It's like a lot of other families maybe outside the US have the US. But if you ever see, and how is your approach for surgery, like it was like severely refractory, has a BNS, and then was desperately trying to find a surgical accommodation, but has a suspicious mutation in a focal, like in the Gatter complex, I didn't see
Yeah.
in a 5.
Yeah.
The video has something called but presents as initially as a focal, but now it's generalized. Do you think it should still go down the surgical approach and
That's
do
it.
like stereo, or
Yeah. This is great. This is very, very good. I'll answer it in two parts. The first part is putting the genetic diagnosis aside. If you have somebody who has focal epilepsy but then starts showing signs of generalized epilepsy, we see this, the common example is when we see it with infantile spasms, where we have somebody presented with infantile spasms, which look like they're generalized seizures and involving the whole body. We do the MRI and we find something local, and that's actually the driver because it is affecting the entire function of the brain. And so even when we see that, we'd still go for surgery. The earlier the better, but there are data that continue to show that there could be improvement because I mean, there are kids who go onto from the spasms to Lennox-Gastaut and they start to, but we could still get some benefit from the resection of that particular area that was the kind of the instigator of this generalized process. And then to go back to the genetics, as you probably know, the gator, most of them are VUSs because of the way they are inherited and that they don't show symptoms in everybody who has them. And so the fact that you've inherited it from your mom or your dad doesn't really help change the classification or doesn't teach us more about is it really the cause of your epilepsy or not. We do our best to try and find people who are doing functional analysis. If we have any other type of tissue that we can look at, we'll try to look at it. But I think that should not really, definitely should not prevent thinking about surgery. And as a matter of fact, the outcome tends to be good with one of these, the gator complex genes. They tend to be really localized to one particular area of the brain. And there's also this theory that you might have the abnormality in your whole body, but then in that particular area of the brain alone, there's an extra change, and that extra change is kind of the cause. And so if you take that out, the hope is that you've cleared as much as possible of that. And so far, the outcomes have been between 50 and 60% seizure freedom. They're relatively newly discovered genes, and so they're starting to look into them, and we don't have a long longitudinal follow-up, but it seems that the outcome is good. So I would say even if they're a VUS, the only difference that it would really make is the counseling and how to think about what is the likelihood of seizure freedom here, or it's a little different in children. We stop thinking about seizure freedom. We're hoping for seizure freedom, but we're also thinking about, I don't know that I would only do surgery if the goal is seizure freedom, because there could be seizure reduction that is very meaningful on the quality of life. It doesn't have to be, one or the other. I think we see that a lot more in the adult world, that, it's either angle one or where you're bothering, but I think there could be a big impact regardless whether you're sure this is going to lead to seizure freedom or not. I hope I answered. I don't know if I answered the question.
Yeah, and obviously then with the imaging, we're talking almost that like a lot of these models are like lesional, all the approaches, but then you have like imaging that's not lesional or it's fractional.
Yeah.
So
Yeah, we're talking about younger kids. Yeah. We try to do whatever we can functionally, like a PET scan, for example. If the MRI doesn't show it, maybe something will light up on the PET scan. We'll have to ask Dr. Stone about doing these seeds in much younger kids. I mean, they are doing them in kids who are younger and younger. And I think if you can prove that, even without an MRI lesion, if you can prove that there is really, really clear focality early on, I think it's worth it to pursue that. I don't know that they have done many more additional studies, but there was this really compelling paper that came from the Cleveland Clinic a long time ago, where they targeted patients with generalized epilepsy who had focal lesions, and all of them did better, but those who had an earlier surgery did even better. developmentally and seizure-wise.
First of all, it was a pleasure to see one of your lectures, knowing that you are my daughter's pediatric neurologist. It was a big pleasure for me. And my question is regarding clinical uncertainty. As you well know, my daughter has not had a genetic problem, but I've heard from a lot of parents in this conference that their kids with clinical uncertainty have found of genetic abnormalities. Do you think that these genetic abnormalities could give better or worse prognosis or in the term of clinical uncertainty?
Yeah, this is a really good question. So the few genes that we know of that can cause hemimegalencephaly, we do see them. So when we check the blood, let's say, or just the cells from the mouth, the buccal cells, and we find those changes, that is telling us, well, we think this change is affecting the whole body. And sometimes children who have, for example, AKT3 or mTOR in all of the cells of their body, not only have the brain malformation, but they do have other areas of the body growth, kidneys, heart that can be affected. That alone makes you think that if it's hemimegalencephaly but the entire body is affected, could there be a higher chance to find something on the other side? Meaning that the surgery could be, not that the surgery itself isn't successful in stopping the seizures coming from there, but then the risk of having seizures coming from another area of the brain. And I don't think we know that for sure. I think that there are particular genetic findings where we know the prognosis in terms of seizure freedom is less favorable than when you don't have a genetic diagnosis. I think part of it is it's very likely that the change has only happened in a subset of cells, and this is what we're seeing on that one side of the brain, but not really in the rest of the body. And that's why we also hope that the other side of the brain would not get affected at all. I don't think that I can say beyond that whether one has a better prognosis than the other. Let's say it's whether somebody has mTOR in their blood cells or has mTOR here. I don't know that there's a difference. But I think with the other ones, like the AKT3, you have it in your whole body, and it's going to affect a lot of other systems. It's also going to affect the development regardless of the seizures themselves. Yeah. Yeah, so I don't think that having a negative finding, I don't think it will lead to any unfavorable person.
So my son, multiple sclerosis, hemisphere brain diagnosed, it's also possible for 11 months. I mean, 2 years. The genetic testing did onto it, I know there is one that was spontaneous, but it turned out to be relative. Brain matter tissue testing afterwards remained negative. Went back and did a street swab with genetics and did exome sequencing. With my husband, and he was found to have an SCN3A mutation. Apparently, 2 years ago we found out about it. Still fairly rare. I think it's still fairly rare.
Still.
We were told we probably would never have the opportunity to get it off of meds because the risk of seizures on the other side is so high. I guess the question is, what is the possibility of, because it's such a rare mutation, is there enough research being done into genetics to possibly create some sort of a targeted therapy for something like a SCN3A, similar to what you have going on with like 2A?
Yeah, absolutely. This is a great question. The tricky part with SCN3A is we're still trying to understand what it's really doing, and that a lot of the children who were diagnosed with it ended up having brain malformations, sometimes on one, sometimes the entire brain basically can be affected. because it is a channel and it could be a dynamic change that's happening in the brain, I think there is definitely a role to try and address it even later, even after the child is born and we've seen the malformation. But I think before we get there, I think there really needs to be a better understanding of what it is. We're waiting for additional data. I know that there is a group in Denmark that's working on a large European series that they keep promising us they're going to tell us more about. And so that might help us better understand, and might also help us understand why with some variants you have this malformation and why with others you don't. The question of whether or not seizure freedom, is impossible because you have that change, I think it's too early to answer just because we don't know the long-term consequences of that gene, because I don't think we have anybody, who's, let's say, in their teens or 18 or 20. No, they wouldn't get tested. Yeah.
Like I said, prior to surgery, at 3A didn't show up. We did
Yeah.
it
It wasn't. Yeah, it wasn't on the radar.
a year and a half after surgery, we finally were like, oh, interesting, this exome sequencing.
Yeah.
To see, talking to her, UCLA.
Yeah.
And the geneticists were there, and like, what's the trial in next hospital?
Yeah.
And so she was saying there's just not enough known about it. I
Yeah.
think there was like one study that we read, and
Oh, Philadelphia. Yeah.
and it was just such a small sample size.
Yeah.
And just the unknowns, I guess. It's hard because we did surgery from what we know he's seizure free. He does have some kind of absence looking things,
Yeah.
but we don't know if it's behavioral versus
Actual seizures. Yeah.
We're choosing to go with behavioral because it doesn't show up on EEG.
Yeah.
But I'm just always so fascinated with the genetics.
Yeah.
Yeah,
No, definitely. I hope so. I mean, these are the things that channels are the more, I think, not that other things are not targetable, but in general in epilepsy, channels they're very dynamic. They change, they turn on and off over time. And I think there can be a good, hopefully.
The thing with SN3A is that the abundance of the protein in the brain goes down. It's really important for development, but then becomes less important. So if there is a mutation here, because that protein is much less important than many of the other situations.
Yeah.
Like assuming that if there's a mutation there, it won't do much. So yeah, that protein is not as important. So you don't know, you can't like say
Yeah.
because it's less important, it's less like.
Yeah. Yeah. With a lot of these things, we have to find a mechanism that's beyond that. Basically, okay, the seizures are set because of the abnormal expression at that age. What do we do next? I mean, is it one of those channels that you can still target with time? Or do you have to jump to the next area and say something down the line where you're like, okay, this has happened, this mechanism has happened, I'll target this one now. Yeah, but I hope we learn more about it. I think what is very interesting to me is just this brain malformation that is happening with it. It's not like the other channelopathies.
So they have at least 5 isolated spots.
Ah, okay. Yeah.
And I mean, a large pregnancy, someone inherits with a mutation, so it's just one of those things. Why did this happen?
I know. It's random. It is so absolutely random, and there's really nothing that anyone could have done to prevent it, or anything could have been done to cause it. But yeah, I really hope that we'll learn more about it with time. I'll stay on the lookout for the study from Denmark and see what they teach us. Thank you.